Well, good afternoon, everyone, and welcome to the Independent Sage Friday briefing. Early in the pandemic, we were told by politicians that they were following the science, but this phrase begs several important questions about the relationship between science and policy. So, for example, what science are we talking about? Is it the lab science of viruses and vaccines, clinical infectious diseases, epidemiology, behavior, or is it social science? What about healthcare science, primary and intensive care, the science of community engagement, logistics, economics, engineering, or even political science? And then if a pandemic is fundamentally about public health, why was there no independent public health scientist on SAGE? And third, if we believe the opposite, that actually politicians should not follow the science because science is fallible and uncertain, what kind of advice do they need? In warfare, we have generals. But in a pandemic, to use the words of Nobel laureate Sir Paul Nurse, who was in charge? Are politicians with a background in banking or ancient Greece the best people to take day-to-day decisions about pandemic management? These are all difficult questions, and there will be more. And we have three experts in the area to join us today: Fiona Fox, Professor James Wilsdon, and Professor Christopher Gray. They'll be joining Professor Deenan Pillay to chair that session. But before we do, let's go over to Professor Christina Pagel for her update and thoughts on the data. Christina.
Thank you. Right, let me share my screen. So a kind of a whistle-stop tour today of lots of different topics. But I guess the headline is we're definitely out of the latest Omicron wave, but we're now kind of counting the consequences of all those infections. And right at the end, I'll show you, it looks like there might be a new wave on its way in a couple of months. So just starting off with vaccination, really the main vaccinations that we're doing at the moment is still the spring booster campaign, although it has died down, but it has made good progress with the majority of eligible adults now have their fourth dose. In England, Scotland and Wales, we haven't been able to find data for Northern Ireland on this. Vaccinations for 5 to 11-year-olds are now available and have been for the last month, but uptake is really, really low. It's highest in Scotland, which has been the case for all of the childhood vaccinations, but still only 17% there. So for, I'm guessing, a variety of reasons, parents are not choosing to get their children vaccinated. For many children, of course, they're not eligible because you do have to wait 12 weeks after an infection, and very many primary school children were infected last term. Looking at prevalence and the latest ONS infection survey data. So this is good news. It goes up to the end of April. We can see that all infections in all nations are declining very steeply, and we're back to kind of where we were just as Omicron started taking off. So, you know, between 2 and 3% of the population infected. That's still historically very high if you look at where we were pre-Omicron, but it is so much better than it was a couple of months ago. And if we look at the ages of people getting affected, we're seeing infections dropping in every age group, which is really good. And we're now seeing much, much, much lower prevalence in school-aged children, which is also really good news. Now, this survey goes up to the end of April, so only about 10 days after term started. So it's a bit too soon to see whether the latest term will start infections rising again. But at the moment, there's no sign of it. So let's kind of take that bit of good news. Looking at hospitals, the number of people in hospital is also declining steeply in every nation again. That is good news. If we're just looking at admissions, you can see in England, they're back down to where they were at the beginning of December. We're well below 1,000 a day now, which is still high, but it's good that it's coming down and should continue to fall for the next few weeks at least. And this is now relieving pressure, some of the pressure from COVID on the NHS, and we're seeing that capacity is going up a little bit in terms of number of spare beds in hospital. If we look at deaths, this is the number of deaths within 28 days of a positive COVID test by date of death. This is across all UK nations, and it goes up to about the 26th of April because it's quite a lagged indicator. But you can see here, the clear bump for the BA1 Omicron wave in December and January, and then the clear bump for the second one, February, March. It does look like this is now coming down. So again, that is good news, but there was a significant wave of deaths in both Omicron waves. And if we look at it by deaths on the death certificate, so kind of the gold standard ONS death certificate registration, where COVID has to be on the causal pathway to death. This is England and Wales I'm showing. They're coming down in Scotland and Northern Ireland, which is good, and I haven't shown it, but it looks as if we're probably at around the BA2 peak now in England and Wales at just over 1,000 deaths in the week to the 22nd of April. It might be around that again. And the coming week, it's a bit difficult to know because we've had Easter and bank holiday reporting kind of delays. But I think what is worth pointing out is that actually, if you look at kind of the overall impact of the number of infections that we've had, you can see, just looking at the total number of deaths, like in the Alpha wave, which is mostly pre-vaccination, there were 66,000 people who died from COVID. Really devastating wave about a year and a bit ago. And then we had the Delta wave, which lasted, 6-7 months. 18,000 people died from COVID. And in the 4 or 5 months that we've had Omicron, 16,000 people have died, and it's very likely we'll be exceeding this level within 2 to 4 weeks. So actually, this idea that Omicron's mild or it's fine or we're all vaccinated, those things have helped keep deaths lower, but they're still really high. There still has been a considerable burden of death from this Omicron wave. The latest long COVID report came out from the ONS survey today using the ONS infection survey data. And it's showing that cases are still going up. They estimate that almost 1.8 million people currently have symptoms lasting at least 4 weeks. That's 2.8% of the entire population, which is, really quite a lot of people. If we look at it just by how much it affects their daily lives, so most people say it affects their lives a little, but a significant number of people are saying it affects their lives a lot. And this is, I think, quite, a sad graph to me. It's kind of how long people have had symptoms for. We're now, over 2 years into this pandemic, and you can see that actually we have a significant number of people who got COVID in the first wave and still have symptoms over 2 years later, almost 250,000 people. I think that's, it's quite a staggering number. We can also see here, and I think this is quite instructive, a kind of a very narrow band, a much smaller number for this period. What was that period? It was a year ago. It was as we were coming out of the winter lockdown in 2021, we had a period of about 3 months with really low infections. And you can see the consequence of that. Consequences of low infections is you massively reduce the burden of long COVID. This number here at the bottom is a number of people who got infected while we've had Omicron, a highly vaccinated population. It matters. It matters that we're having these high numbers of infections. For the first time as well, ONS today released their estimate of how many people are reporting long COVID symptoms after they've been vaccinated. So this is people who've had 3 doses, who've all been boosted, and this is their first infection after vaccination. And what they're showing is they're comparing it here by different variants. But the main takeaway for me is that for Omicron, it's somewhere between 8 and 9% of people who have Omicron after 3 doses are reporting long COVID, at least symptoms after 4 weeks. If you actually look at it by people who say it's limiting their activity, that's 5 to 6%. So yeah, it's lower, but it's still a really high proportion of people who are getting long COVID. So it's not the vaccination will stop you getting long COVID. It reduces the chance, but it's still a significant number of people are reporting it. And it matters as well for the economy. And you can see here just by some sectors, particularly the sectors that are incredibly exposed to infection, social care, teaching, education, 4 to 5% of everyone working in those fields is reporting long COVID. And the question is, if we keep having new waves, how sustainable is that? Speaking of which, just going to finish on new variants. This is just an overview of the dominant variants in England since the summer of 2020. So we had the Alpha wave, then we had several months of Delta, and then the two big Omicron waves, BA1 and BA2, we're just coming off the back of BA2 now. You can see here, just looking at the proportion of sequenced positive cases that are BA1 and BA2, we had this really rapid surge of BA1 in December. That started coming down in January. This was kind of a little lull in infections while BA2 was growing and BA1 was falling. And now BA2 remains dominant, but infections from BA2 are dropping. So what is coming? Well, South Africa has kind of started another wave that's driven by new Omicron variants. There's one called BA4 and one called BA5. They're mainly concentrated in two provinces. And especially in those provinces, cases, positivity rates and hospital admissions are all rising. It certainly does seem the case that there's a growth advantage of these over BA2. So this is the BA1 wave in South Africa. BA2 wave, which was much smaller, became dominant but didn't cause a big wave of infections. And now BA4, BA5. It's still early days, so there's no sign that they're more severe. There's no sign that the vaccines work less well, really, but it's certainly, something to keep an eye on. In the US, they have a kind of a child of BA2, which is what we've just had, called BA2.12.1, that's driving a new wave of infections there, particularly in the northeast of the country, that has reasonable transmission advantage over BA2. And just going back to this graph, you might be able to see that just at the very end, the very last point, it looks like this is coming down. And that is because while BA2 is still dominant, those three variants are all starting to grow here in England. So this is England. This is the proportion of all sequences that are BA2.12.1, that's the one in the US, BA5 and BA4, the ones in South Africa. You can see they're all about 0.5% of cases each now, which is still really small numbers, really still low proportion, but it is growing. We know it's been growing in other countries. So it does seem likely that they will continue to grow here. Now, what that means in terms of absolute number of infections, we don't yet know. So just to summarize, we've been making good progress in giving eligible adults a fourth jab, but we've been making barely any progress in vaccinating 5 to 11-year-olds. All nations are showing declining cases and hospital admissions and deaths, apart from England, but I think we're probably at the peak in England and Wales. And we're definitely on the downward slope of the BA2 wave. So far, there isn't any sign of an increase in school infections, which is good, or other infections in school-age children, but it is still quite early days because it only goes up to about 10 days after the start of term. Long COVID is rising following the Omicron BA1 surge, so we haven't yet seen the impact of the March BA2 surge yet in this data. And this is in a highly vaccinated and highly previously infected population. And while Omicron BA2 remains dominant, there are 3 new Omicron variants that are all growing roughly at similar speeds. But one of them probably will become dominant. We don't know which one. And whether it will cause a smaller or larger wave of infections if it becomes dominant remains to be seen. But size matters, right? Every infection is potentially someone who will end up with long COVID or end up in hospital or even die. And on that note, I'm going to finish.
Thank you very much, Christina. Great data as usual. So now we're going straight on to the main session on science and policy. Over to our very own Deenan Pillay to host this segment and introduce the guests. Deenan.
Thanks, Anthony, and thanks, Christina, again, for a really informative presentation. So our strapline at Independent Sage is following the science. A bit of a provocative take on, of course, the government mantra right from the beginning that it would be guided and it would follow the science. And we want to spend the next half hour or so just deconstructing what that means. First of all, how do scientists such as ourselves communicate? Is there one science? Are there many sciences? There are a lot of contested areas, different disciplines. Secondly, what's the framework within which policy is made? What structures are there that allow the scientists to actually to stimulate politicians to follow and policymakers to follow the science? And thirdly, and importantly, what is the context in the UK, particularly in a sort of post-Brexit world, where there's been really a fair bit of dysfunction at government level between ministers and, of course, in civil servants. And of course, so we've got three wonderful speakers who are incredibly knowledgeable and in the right position to inform this debate. We have Fiona Fox, who's a chief exec and founding director of the Science Media Centre, which since established in 2002 has become an indispensable resource for science journalists, and many of us here get their information and also feed in our views through that structure. She's had a degree in journalism, many years of experience working in media relations, high-profile organisations, and author of a very recent book, Beyond the Hype: The Inside Story of Science's Biggest Media Controversies. Secondly, we have James Wilsdon, who's a professor of research policy at the University of Sheffield, director of the Research on Research Institute, which is an international consortium aiming to improve how research is undertaken and to lead that research to impact. And thirdly, and not least, Chris Gray, an emeritus professor of organisational studies at Royal Holloway, University of London, previously professorships in Cambridge and Warwick as a fellow of the Academy of Social Sciences, and has written extensively on Brexit, including the book Brexit Unfolded, and I must say produces a must-read weekly blog on the post-Brexit government machinery. So with no further ado, each of those speakers are going to speak for 5 minutes, and then we'll have a discussion within ourselves, but also those speakers are available for potential questions from the public later. So to start with, over to you, Fiona.
Okay, thanks very, very much, and thanks for inviting me to take part in this. I'm looking forward to the discussion. So I thought what I'd do, as you said, my area of expertise is getting scientists, including many of the faces I see on the screen, to speak to journalists during any major science story, but in particular during a kind of national crisis. We have actually spent a bit of time doing a piece of work on our lessons learned. Everybody seems to be working on lessons learned, so we thought, well, why shouldn't we? And Fiona Lethbridge, a colleague in my team, has led this piece of work. And it's very new, and I'd love you all to have a look at the 9 lessons learned. We were trying to get to 10, but we didn't want to create one just for numbers. So there are 9 lessons learned, and I'm just going to talk about 4 because I think they're relevant to this discussion. So the starting point is to say that we feel actually quite positive on this one issue of the pandemic, that scientists did engage in very large numbers with the media and the public, and that is something to celebrate. But our first lesson learned stroke recommendation is that we have to keep doing that. I really want that to be a lesson learned. Just because it happened, I don't think we should be complacent. I talk a lot in my new book, which Deenan mentioned, about the constraints on scientists engaging with the media, whether that's through the government communication system or even through their own kind of corporate PR officers. There are quite a lot of scientists who do say to us, I'm afraid I'm not allowed to speak to journalists. So we must celebrate the fact that scientists did that. It made an important change to public understanding of the pandemic, and therefore we have to do that in future. We need to remove barriers and constraints and allow scientists to speak directly to the media. That's number 1. Number 2 is one that I wanted to read out completely. It's very short, but I think this one is perhaps controversial, and I'm very happy to discuss it during the discussion item. So it's about scientists staying in their lane, and being sciencey. And I'm just going to read out what the recommendation says. So it says, public interest is best served by scientists who comment within their area of research and expertise. Scientists specialise for good reason. When everyone in the country is an armchair epidemiologist, scientists should speak from the evidence and with reference to research and data, not opinion or ideology. Scientists need to earn the levels of public trust and government trust and demonstrate trustworthiness, judging each piece of evidence on merit and changing their minds as the evidence changes. And finally, scientists should rule themselves in and out of particular media interactions based on their expertise and help journalists and the public understand the degree of confidence or uncertainty they have when assessing new scientific studies. So that's our the second lesson. The third one is really one that I think you will definitely agree with, which is around the kind of need for multiple voices. We often find ourselves at odds with people, especially government communications people, who want one single public health message. We think that is not sciencey. Governments are entitled to have single public health messages. Probably is very beneficial to the public so that they're not confused by different messages, but certainly on something like this virus, which was so little understood and so new. So we are champions, and that's what we do. We have 3,000 scientists on our database, including many of you. We want to put those different voices up. If they're good scientists, then we're interested in putting them into the media, and we think that they should thrash out, or you should thrash out your differences openly and scientifically. And I do just want to stress that last word. We all felt in my team that there was too much, even amongst scientists, there were too many scientists shouting each other down. And one of the things I thought we did learn during the pandemic was how scientists can show the rest of society, actually in a very polarized society, how to debate better. Passionately, yes, absolutely, vigorously and robustly, scientific differences, but not putting ourselves into camps, or not taking a position and talking about facts and evidence, not our opinions. Because otherwise, why be a scientist if we sound like a columnist or a politician or a pundit? And showing humility is very important to us. And I think that, especially in the pandemic, when so many scientific issues were unresolved and uncertain, and maybe outside of scientists' particular area. And fourth and finally, and probably most relevant for the discussion we'll have, is about scientific advisors to government, and I mean the official ones. So the independent scientists who sat on the official SAGE and the different subgroups of SAGE. We feel very strongly, and one of the recommendations says that these scientists must be encouraged and supported, and indeed even expected to also speak to the media in their professional capacity as a leading scientist. So I think that largely happened with independent members of SAGE. By independent, I mean the kind of university scientists or the Jeremy Farrers, those types. But that it hasn't happened in previous SAGEs. And we've battled on things like Fukushima and volcanic ash and Novichok, where actually scientists who joined the official SAGE were kind of told, your job is to advise inwards behind closed doors to government and not to speak to the media. So it was actually progress this time that we did hear many of these scientists speaking on TV and radio in their scientific capacity. And we want that to be one of the other positives that we take forward. So that's my 5 minutes. I don't know if I took it all, but that's my pitch.
Great, Fiona. Thank you very much. So straight on to James Wilsdon.
Great, thanks, Deenan. Well, yes, I mean, I agree with much of what Fiona's just said. A few points from me. Let me pick up first on Fiona's use of the word humility there as one of her points. I think humility is a very crucial virtue of an effective scientific advisor, indeed an effective advisory system in any respect. And I think one of the key questions now, as it were, 2 years on, is to what extent is there visible humility in the structures, institutions of advice that were and continue to be so crucial to the UK response to COVID and to other things, and where's the learning? Where's the learning taking place? And I think that is quite an open question at this point. A lot of these things have been well discussed, so I won't labour them, but I think we have to continue asking, why we forgot earlier lessons at various crucial points that we had painfully acquired, knowledge that we painfully acquired from earlier controversies and crises, but which seem to be lost in the heat and urgency of the moment. So lessons around openness, around plurality of expertise, around acknowledging uncertainty and trusting the public to cope with uncertainty rather than oversimplifying things and all this talk of the science as a singular thing being a symptom of that. The existence of independent stage, I mean, I think is it an indicator of a system that's working well or working badly? I mean, I think there's a genuine important debate to have there, especially 2 years on. Clearly it was and in many respects is filling an important gap, a vital need, a really crucial need early on when there was such little transparency from the real sage, as it were, the real machinery. But I think the question is, in our advisory structures, where are the spaces and places for the kind of open, plural, public-facing, public-engaged debate that Indy Sage is providing, that Fiona is also talking about when she's emphasising the importance of communication from advisors, not only sort of upwards and inwards, but also outwards. So I think all of these things need to be reflected upon. Are the structures that we have inherited and we have relied upon very heavily through the past 2 years, Sage, obviously, real Sage as it were, being the most prominent amongst them, but certainly not the only one. Are they fit for purpose? There has been some discussion of this, through various select committees, but I don't think there's a clear sense of an urgent imperative to review or revisit how we have approached these things. And I think just a couple of final points. I think if we look at the formal terms of reference of the COVID-19 inquiry, the Baroness Hallett inquiry, as several have pointed out, advisory systems and structures are quite, they're sort of implicit in discussion of public health decision making, but they're not explicitly part of the remit of that inquiry, which I think is perhaps a missed, an important omission, as it were, a missed opportunity to bring focused attention to some of these questions. And I do worry that there's a degree of complacency that has crept back into the way the system regards itself, if one can put it in that way. I'll give us one quick example. I mean, a couple of years ago, before COVID, Richard Jones, who's at Manchester, and I wrote a big piece called "The Biomedical Bubble," which was a report, and it called, in reasonably provocative terms, for a greater focus in health research investment on public health. It called for more plurality of decision making. It called for more openness and engagement with the people and the parts of the country to whom the health system should is there to serve. I heard only secondhand, as it were, a recording of Patrick Vallance standing up at the Royal Society a couple of weeks ago, talking about that report and saying how now, of course, these people who've been saying there was a biomedical bubble have been shown to be completely wrong. It's all the bubble is alive and well, as it were. And one could argue, there's certainly things in that argument I would phrase differently in light of COVID-19. But I think that reflects a certain epistemic arrogance as opposed to humility. And I worry about that. And I worry that the same people who are in charge are sort of tasked with kind of looking at how we might potentially tweak and improve things, which I'm not sure is a sufficiently urgent, radical and fundamental response to the questions and challenges posed by the past 2 years. I'll leave it there. Thank you.
Thanks very much, James. And then last but not least, on to Chris. Remembering that when we came into this pandemic right at the beginning of 2020, we'd just come through some political upheavals in the UK. So Chris, over to you.
Yeah. Okay. So I'll just talk just very briefly about the kind of Brexit background to the pandemic and maybe try to indicate some more general points about it. And the first thing is precisely that timing, that COVID arrived in the UK when we sort of had, 3 or 4 years of Brexit and the Brexit process, but actually we were still right in the middle of it. I mean, we were just at the point of signing the withdrawal agreement, and the negotiations about the trade agreement began pretty much on the same day as the first UK COVID death occurred. And then obviously the first lockdown came in March as those talks began to get underway. But in a sense, it sounds banal, but there's a general point there as well, which is that there's always something else happening. There's always going to be something else happening at the same time as whatever, whether it's a pandemic or some other thing. Of course, there was a key issue about the orientation of this particular government, which had only just been elected in December 19, which was that its whole orientation, its kind of raison d'etre, was to get Brexit done, and moreover to get Brexit done without any further delays. And that you can articulate that as a criticism of the government's response to the pandemic, but it's also important, I think, to understand that the question of what is a political priority is by definition a political question. It's not a scientific question, and so so one can't sort of automatically assume that the policy-making focus and the administrative focus is going to be with the thing that perhaps scientifically one might think that it ought to be. And that orientation of the government, you can point to a series of ways in which its get Brexit done orientation impacts on dealing with the pandemic. And I think one particularly important example is that the refusal to extend the transition period in the Brexit process. The point to make the decision was at the end of June 2021, and the rational thing, if you like, in the context of a pandemic going on, would have been to extend, but politically, the idea of extension of transition period was just an absolute kind of anathema to the government, and it didn't happen, and that contributed. So that's my first point, which is about the orientation and priorities of any government, but in this case, the Brexit government. And then my second point from that is the whole question of administrative bandwidth, and one of the legacies of the so a few points, but one of the legacies of the years of the Brexit process have been really probably quite extraordinarily and historically poor relationships between ministers and civil servants, that the civil service almost en masse was seen as being somehow oppositional to Brexit, to have been, perhaps even been trying to obstruct it. And at the same period we're talking about with the pandemic, you've got Dominic Cummings and the Vote Leave advisory team, and the idea that the hard rain was going to fall upon the civil service. So that in itself was problematic. But even without that, Brexit required a really huge administrative bandwidth that affected in some way, I think, almost probably every department of government. And you had high levels of civil service staff turnover, unusually high levels of civil service staff turnover, and particularly at senior levels. And so you have these periods when, all the way through 2017, 2020, and this is, I think, established and on the record, that the intensiveness of no-deal planning was such that was one of the reasons why the recommendations from the 2016 Cygnus exercise on pandemic planning were never implemented. And then in 2020, there was a whole process of intensive planning for no deal in a different sense, in the sense of there being no trade deal. And so that was where the focus of what administrative resource was available was being put. But again, there's a general point here, which is that there will always be constraints on administrative bandwidth. There will always be constraints, and so the pandemic or anything else which is happening will always be competing in that sense for administrative resource and for political attention. And then there's the third broad point is the kind of the political and ideological orientation of the government, not just in terms of getting Brexit done, but I think that carried over from Brexit was a certain kind of climate of anti-rulism, and so a hostility both to the idea of sort of bureaucratic systematicity, which was necessary to deliver the response to the pandemic, at scale, but also obviously restrictions on individuals, and so that inflected things. And again, the context there is that you had this government with a large majority, an ostensibly large majority of 80, but it was always much, much, much more, and is much more fragile than it seems, in particular because the ERG, the European Research Group, who were really much more loyal, I would say, to the kind of party within the party than they were to the Conservative Party, were always ready to rebel. And the crossover of that group with the COVID recovery group, who had typically sort of hostile, I guess, to sort of restrictions and lockdowns and so on, meant that you had these political constraints as well all the time as the pressure from outside the government, from the kind of Farageist right, which in terms of a kind of in terms of a party strategy, would always need to sort of be outflanked. And so, but then my more general point is that there are always political constraints of that sort. The details will be different, but those were the particular details in this case. But that will always inevitably mean that following the science in and of itself is an inadequate and almost meaningless notion in the context of political constraints. And one can argue about what should be prioritised, and that's certainly right. But what happened with Brexit is, in one sense unusual, but in another sense entirely typical. So that's
Thank you very much. Thanks, Chris. So that's a really wide-ranging but very a sort of set of topics squeezed into that period of time. What I'd like to suggest, if our MC and chair Anthony is happy, is we take some questions on this these presentations internally for the next maybe until 15:15. Then we move to questions from the public, because that's an important priority of our public engagement. I'm sure that there's a lot of interest, so we're trying, if you can all keep your questions brief, and try not just to give another 5-minute presentation, and so that we can get our guests to actually respond to it. So who wants to start? Susan.
Thanks, and thanks to the speakers. Really, we could have had a long session on each of them, and so much to say. I mean, I was on SAGE in 2009, and again over the last 2 years. We could have spent hours, I think, really analysing and thinking about that. But I wanted to ask a question and make a comment in terms of what Fiona said. The question is about something that I think really put me off engaging with the media and how to handle that, which was the media polarising debates for the sake of it. So I would accept to go on and speak, on behalf of my scientific expertise, only to find out that I've been put up against somebody with some stupid question, basically, that just didn't help anything. And so I did learn to say, who am I going to be put up against? And no, I don't want to be involved in that, and withdraw. But anyway, any reflections on that? Because I think that was very damaging, both to the engagement of scientists, but also for being able to communicate information helpfully to the public. The other thing I did want to comment on, and I agree with a lot of what you said, but I think there's a lot of questions raised by it about this staying in lanes. Absolutely, we're there as scientists, we're there to share our evidence, bring to light new data, theoretical ways of understanding issues. But we also are there to interpret that within contexts. And all the research that I've been involved with, public health research, health service research, implementation research, always in a very interdisciplinary way, not multidisciplinary with different disciplines staying in their lanes, but interdisciplinary, where you really learn about each other's ways of thinking, some of their evidence, etc. And because we're trying to give a picture informed by science as to what's going on, and because pandemic management itself is inherently multidisciplinary, as is public health, inherently multidisciplinary, you do need, epidemiology and behavioral science and many other sciences all coming together and understanding each other. So I feel the absolute key is to be very clear about what you're confident and what you have a degree of certainty about, and what you're not confident about. And often if I were asked about things that I felt I didn't know about, I would say, my colleagues have told me this, or from what I understand, but this isn't my area. However, I do think that it would be hopeless if I was only going to go and talk about a narrow bit of behavioural science. You know, one has to contextualise it. One has to bring in what one knows from other sciences. Indeed, even in the behavioural science group within SAGE, we had anthropologists, sociologists, psychologists, communication experts, implementation scientists, all with very different theoretical and empirical bases. We learned a lot from each other and really gained, and were able to communicate that to the public. As I would argue, we have also done on independent SAGE. So I think it's a big debate, but I think just saying, stick within your expertise, stick in your lane, I don't think that really answers the question. And we need to think about the broader communication strategies that scientists are involved in.
Thanks, Susan. Can I suggest that we just take one more comment? Martin's put his hand up, and then we get some reflections back from the panel, just for the sake of time. Thanks.
Yeah, to some extent, I want to echo what Susan said. I'm a public health physician, and my previous research has been on things like the post-Soviet mortality crisis, the health impact of the global financial crisis. And in that work, I have published on a whole range of topics with experts in those areas, all the way from the pathological mechanisms through the epidemiology through to the political science. And I don't claim to be an expert in all of them, but I would argue that by working in an interdisciplinary team in partnership with those colleagues, I feel perfectly confident about talking about those issues. So I'm not sure where my lane is, because when I'm dealing with a really complex phenomenon, if I was to stick in my lane, it would be a little bit like the parable of the blind men and the elephant. So I could become an expert in the trunk or the leg or the tail, and that doesn't actually help me to understand the nature of elephant behavior. So I really share Susan's point. I just think from a public health point of view, we have to actually take a broad perspective. Otherwise, we are being reductionist and we're losing the plot.
Great, thanks, Martin. Any other comments, particularly, we've obviously done the staying in your lane. We've got a response there. Anyone want to raise? Not if not, I'm not seeing any hands. I would just want one final question before bringing in the everyone is, and it's a question really to James and Fiona in the context of what Chris has said, is that we've all witnessed different political epochs, really, and it was clear that this is a very dysfunctional one in terms of the normal process of government. And I'm just wondering what, again, your reflections are compared to previous times as to how, and the pandemic, of course, has been, it has affected everybody. Everyone's had to be impacted on this. What that environment has meant to how policy discussions, science into policy has meant. So that would be my comment. But why don't we just go past, have all of the guests, comment a little, just briefly, just sort of half a minute on what's been said before we move over back to Anthony. So maybe starting, Fiona, with you.
Yeah, so I totally accept what Martin and Susan have just said, and I think this is something that we could debate for hours. I think the lines are blurred. I think a general public health expert, a behavioural scientist, is going to be able to answer a lot of the questions that were raised by journalists. So I agree with that. But I think our view, there's a long history to our view here. When we started in 2002, plant scientists who were testing whether GM crops worked in field trials, etc., were not part of the GM debate. And you had people like Susan Greenfield, great neuroscientist who set up the Science Media Centre, Robert Winston, do you remember that? Leading fertility expert, furious with this anti-science debate, anti-GM, and kind of wading in to defend science. And very early on, we really believed it. We need to get the plant scientists who are doing the field trials, who don't think GM is safe. That's why they're testing them in trials, who do think that there could be an impact of this new approach on biodiversity. They spoke completely differently. They're environmental scientists. to some of the kind of big beasts who came in to defend it. And so we've always thought, if politicians are generalists, okay, and they do, they are Home Office Minister one week, and then they're moved to Secretary of State for Education or whatever, and that's absolutely, we all accept that. Scientists aren't, and your whole background, your whole training is to study certain areas. Now, as you're saying, Martin, within that career, you will do lots of different areas, and if you've done research on it and you're knowledgeable about it and you're reading all the studies and going to all the conferences on 10 different issues, then there's 10 issues that you can speak to the media about. But I think there is some kind of philosophy here where you just think, is there a better scientist? The interview is about immunology. Danny Altman, our colleague on Independent Sage, is a brilliant immunologist. We're going to say, can you please speak to Danny on this one? This is not me. Or David Spiegelhalter has said it. And actually, Susan, in answer to your first question, that attempt to polarize and to get the scientists on the Today programme to condemn one camp or to speak outside of their area of expertise. David, live on air, says, I'm not going to be drawn into this. I'm a statistician. I know about everything about statistics. It's very wide. I'm not talking about narrowing here. And I know that science is moving away from that kind of narrow expertise. All I'm saying is, why do you become a scientist rather than a politician or a columnist or a pundit? It is to study one area, one field, very, very clear. And that distinguishes you from the rest of the people in the media. And I did want to sometimes say, when I heard scientists operate, on the television, talking as complete generalists, but, answering every single question that was asked. I just think, how have you distinguished yourself as a scientist? Because if you sound like the politicians and the pundits, then I think the public will think, oh, well, that person's got an agenda or whatever. Okay. So I think it's a broad philosophy and trying to resist being taken too far outside of that expertise, which could be very wide. Thanks.
Very, very literally 20 seconds, James and Chris, on reflections, and then we'll move on. Thank you very much, Fiona.
Yeah, this is fascinating. The lane thing on the, was it a particularly bad period thanks to Brexit? I think Chris's analysis of the whole saga is brilliant, and I've followed it very closely. I think in terms of the scientific advice system, no. One of my favourite history of science books is by Steve Shapin at Harvard, and its title is Never Pure, Studies of Science as if it was produced by people with bodies situated in time, space, culture, society, struggling for credibility and authority. I think this is, and he's going right back to the 17th century. So I think, this is a perennial, but certainly Brexit didn't help.
Yeah, thanks a lot. And Chris?
My only observation is not really about science, but just in general, is that it's often difficult for the media and for the public to understand just how narrow academic specialisms often are and they kind of have become. And that gets very difficult, say, in the context of Brexit, because you might do media stuff and they want to talk to you about trade. But within trade, there are huge differences between somebody who knows how to do trade as a business person compared with someone who knows what trade means in terms of negotiating trade deals, compared with, say, someone who's a trade lawyer. And it's very, very, it's very difficult to kind of articulate those differences because they're only really apparent when you're inside it. Yeah. So that's
thank you very much, and thank you to all three of you. It's been really, and as Susan said, there could be far more we can discuss, but it's been very illuminating, hopefully also useful for our viewers. So with that, pass back to Anthony to get some public questions.
Thanks, Deenan, because do stay around, because the first 2 or 3 questions are about this subject. I would remind people that the great biologist E.O. Wilson wrote a fantastic book called Consilience about the importance of scientists not staying in their boxes and getting together in group meetings like this to share stuff. But I agreed with Fiona's call for scientists to stop shouting at one another, although I do remember an acknowledgement on one research paper that said none of the research would have been possible without all the bitter professional vendettas that kept me going, which I rather liked. But anyway, science is a mixture of collaboration and competition, and sometimes it does spill over. Right, first, from the press, we have a question from Sabrina, an Italian journalist with Il Fatto Quotidiano. During the COVID pandemic that I have covered as a foreign correspondent here in the UK, I've often struggled to discern between scientific advice and political spin. What are your proposals to make the relationship work better? Separate press conferences, ? Dedicated communications channels. So that's one thing about advice and spin. A second question, what is the real current power balance between scientific advisors and politicians in the UK right now? And how does this impact the effectiveness of communication? And linked to that, a third question, I'm going to put them all together from the public, from Marianne, I think. I'll check that. Who's asked, who is advising the government right now on COVID? Are they also speaking freely to the media? So does anyone want to pick up on that? Scientific advice, political spin, the current power balance between scientific advisors and politicians, and what, who's doing the advising right now? Anyone? Hands up. Christina.
Just on who's giving advice, the one body where I feel like there's never been any transparency is the Joint Biosecurity Centre that was set up, a year ago, a bit longer ago, and were supposedly, like providing thresholds for changing mitigations and stuff. And we never knew who was on it, what their advice was, what the threshold was, whether government decisions were based on the JBC advice or on SAGE advice, because SAGE advice was public and the reports and the minutes were out there and they were, I think very comprehensive. And yet sometimes the government, quite often the government didn't follow that advice, but were they then following the JBC advice? Was it political decisions? We never really understood how the government made its decisions because it wasn't often following on from what the SAGE reports are. So I think that is an area where I still would like to know a lot more.
Aris, did you want to say anything in this regard?
Not at this point. No, my points have been captured by others, actually. So
okay. Anyone else with a hand up that I can see? Oh, Deenan. All right, Deenan, you can say something.
Well, I just say, I think, I don't mind it saying it, I think we're in a crisis in terms of our scientific infrastructure in this country. I think UKRI, which encompasses all the research councils, is clearly in a complicated, difficult place. Their political appointments or blocking of political appointments of political into chief executive roles of these research councils that previously were relatively independent. There's a discussion with ARIA, the sort of Cummings type of new structure, which is meant to, kickstart the British scientific economy, which seems they've appointed a director who seems to have gone before even starting taking up their position. We've got, of course, in the course of the pandemic, the PHE, which was previously Health Protection Agency and previously Public Health Laboratory Service, that itself was disbanded. There was a development of the National Institute of Health Protection, which was transient in existence. There's a JBC, now all within UK HSA, which itself has been announced their major financial cuts. So I really do worry that the whole of the scientific infrastructure of what was once, I think, a very high quality structure within the UK is disappearing. And just at the time when, in fact, we want to have the strongest and most robust structure for protecting against the continuing COVID and future pandemics.
Thanks, Dean. A very quick comment from Zubaida, and then I've got two more questions I want to get through. Zubaida.
Well, I just picking up from what Christina was saying about transparency, I was thinking one of the biggest and most concerning areas where there was an utter lack of transparency about the scientific advice and where I felt there was the most politicization of scientific advice was in education. When it came to children in schools and how to protect children in schools and the mitigation measures in schools, it was completely unclear. And I think that was really concerning. And there was no separate, really, there is a big question about why wasn't there separate consideration about children and young people in schools? And there wasn't any specialism there at all. And I think looking ahead, looking forward, that's something that we really need to talk about.
Okay, Steve, I'm going to bring you in a minute because the next question is really up your street. So actually, I'm going to read out the three questions and then see if we can pick them off. So one is from Keith Bavistock, who said there are various reports that there are drugs that might relieve long COVID symptoms, aspirin, clopidogrel, apixaban, prednisolone, fluvoxamine, for various reasons, but treatment is denied on the ground that their use would be off-label. There's no randomized trials to prove their value against the risk of side effects. He says, but surely the risk should be weighed, not those of adverse side effects, but rather the risk of continuing to experience symptoms that might lead to long-term tissue damage. Is it not time to treat long COVID as a serious public health problem and use trial and error in an attempt to find solutions to this multifaceted problem? So that's definitely one for you, Steve. The next one is a question from last week that I must get in from Fraser and Graham that we couldn't cover. Why is there no apparent pressure being put on government to provide free FFP2 and FFP3 masks for the clinically extremely vulnerable, the immunosuppressed, other vulnerable categories? And finally, one from Joanne in Essex: how concerned should we be about the new subvariant Omicron XE? So let's start with Steve on all the antivirals for long COVID, or treatments for long COVID.
Yeah, okay. Thanks, Nancy. Actually, that's an important point to make, that many of these things aren't necessarily targeting viruses. So many of these proposed therapies for long COVID are potentially modulating immune responses or metabolic errors or disturbances, or have, fairly interesting methods by which they're thought to potentially affect the development or maintenance of long COVID, fluvoxamine being an obvious one. It's really hard. And I think when you have an emergency situation, as we did at the beginning of the pandemic, then yes, you are justified in trying to repurpose things as quickly as you possibly can. The cost of that is that you can end up in the sorts of situations that we had with things like ivermectin, hydroxychloroquine, etc., where off-label use of this becomes almost a sort of belief-led rationale for using these agents to treat things. And I think that things like the recovery trial and Solidarity and other things that we have ongoing at the moment really show the value of a well-controlled trial to really determine what's going on. The difficulty we'll have with long COVID is understanding the etiology of long COVID and understanding how we understand whether these drugs are actually working. And I think we have to adapt our systems to look at something like this, and it's something we have to adapt to other long-term health conditions to ascertain whether something is beneficial. You cannot discount self-reporting and all that sort of thing that we see from the ONS statistics, but it's actually a really hard thing to do to get the right patients that are most likely to benefit from those treatments. So I'm not really a fan of off-label treatments. I'd really prefer we did it properly with randomized controlled trials. I would urge governments to invest in those trials.
Unmute. Sorry, anyone else like to comment on that? Sheena or Aris? Sheena. Professor Sheena Cruikshank, sorry.
I'd like to just add to what Steve just said there, because I think there's a real risk with doing off-target uses, is that you could have unintended consequences, both for patients. We saw that with some of the uses of the drugs earlier that were discussed, but also it can cause shortages of drugs that are needed for other conditions. And again, we were seeing that before, where really vital drugs were being taken away from those who really needed them. And actually, at the moment, I think it's really important that we are careful about the drugs that we take, because we know, and Brexit could be one of the factors for this, that we are experiencing drug shortages at the moment, and there's a real issue around access of certain drugs into the UK. So I think clinical trials are the way forward, and I again urge the government to do this.
Good. Well, I'm glad about that. I can tell my wife to stop force feeding me beetroot juice for my long COVID symptoms and say we need a trial first. Thank you. Right, on masks. FFPs 2s and 3s. Why are the government not doing this? Anyone? Helen?
No idea.
Yes. Should they be?
Well, if we want to protect people, and the ideal protection is both the source of the virus, so the people who are infected, maybe asymptomatic, and the person who's vulnerable to be infected, both wear masks. And in other countries, there has been a lot of provision of masks. That hasn't happened in this country. And sure, I mean, it would be great if we could have, I do think we should have masks back in unavoidable public places, on public transport and in closed public areas. I also think that we should provide good quality masks to people who are most vulnerable. They're really, really not expensive. They're an awful lot cheaper than looking after people. So the economics, people who get ill with COVID. So the economics absolutely would be in favour of providing good quality masks to people who need it. It's the humane thing to do. Yes, we should have masks.
Sorry, Helen, can you not prescribe, because they're about £5 each, but can you not prescribe masks for pensioners or? No,
they're not £5 each. If you have, there are different sorts of masks. There are FFP3s or N99s, which have to be really closely fitting and they're quite uncomfortable to wear. And I wouldn't recommend that everybody wears those all the time. But then there are the sort that just fit a little bit better than the ordinary surgical masks, the sort that I wear with all my clinical work and also when I'm in indoor spaces. They're called N95s because they're kind of supposed to reduce your exposure by about 95%, which is really, really useful. And they are not more than 50p each. I mean, they're really, really quite cheap. You can buy them online quite easily. Alas, they're not prescribable. I wish they were.
We're nearly, thank you, that was very helpful. We're nearly out of time, but this question about the subvariant Omicron XE, could anyone, who's good on that? Duncan, Aris, Steve, who would like to have a go on that? Steve.
Yeah, I think a lot's been made about these different recombinants. They're not spreading as fast as the different Omicron sublineages, which Christina spoke about in the briefing. They are viable in the sense that they are able to transmit, cause disease and pass between people. XE in particular is an interesting one because it hasn't swapped the spike protein. As we've seen in other recombinants, it's swapped part of the machinery that the virus uses to replicate its genome. So we don't really understand what difference that has made to this virus, but it is viable. What it, I think, shows, as with all of these sublineages and different variants that may or may not emerge in the near future, is that this virus is not done changing. And so that's why we need surveillance. That's why we need FFP2 and 3 masks. That's why we need to extend our vaccine coverages. And that's why we cannot just ignore this virus. And we need to make sure that everyone can live with the disease.
Thank you very much. We are sadly at time. That's been a fantastic discussion. Thank you hugely to our 3 guests today. Thanks to all the members of the public who continue to support us. That's a wrap up now. We'll see you all next week, same time, same place. Stay safe and keep well. Thank you. Bye.
Cheers. Bye. Thanks all.